Hi, everyone. We're going to get started now. So welcome to this afternoon session of Social Norms in Health and Education at the CSAE conference. We're very happy to have you join us. So we've got 4 great papers this afternoon, all coming from different angles on looking at social norms. So thanks so much. And I'm going to pass it straight over to Anisha to kick us off.
Great. Thanks very much, Claire. Let me just share my slides. Please let me know if you can't see them. It's really great to be here at this virtual edition of the CSAE conference. This is a paper I've written with Garima Rastogi, who I'm very pleased to say is going to be joining Oxford as a graduate student later this year. The context for our paper is a widely documented phenomenon of missing women in countries which are very strongly patriarchal societies and a particularly strong norm around son preference. So missing women manifest themselves through very skewed sex ratios in favor of men. And this exists primarily because of the practice of sex-selective abortions of female fetuses, in some extreme cases, even female infanticide, and more generally through the gross neglect of female health that leads to higher female mortality relative to males. So in response to this very skewed sex ratio, a lot of governments have responded with what we term supply-side measures, such as laws that ban access to abortions, that restrict the use of ultrasound technology, that prevent medical practitioners from sharing with patients the sex of the fetus that they are pregnant with. And countries that have introduced legislations like these include India, China, South Korea, Taiwan. Unfortunately, the implementation of these kinds of supply-side restrictions, which do not do anything to address the underlying social norms that drive son preference, can simply have the effect of displacing prenatal discrimination towards postnatal discrimination. So one example of this is a small body of literature that looks at the impact of the widening diffusion of ultrasound technology in the 1980s and 1990s on female health outcomes in countries like India and China. So while on the one hand, the spread of ultrasound technology led to a sharp fall in the number of female births, they also improved the health outcomes of surviving females because these females were now born into households where they were relatively more wanted and faced less discrimination. Conversely, legislations that restrict access to abortions or to restrict the use of sex-selective abortions or the use of diagnostic techniques that can be used to detect the sex of the fetus, these may increase the number of female births, but they could also lead perversely to worsening parental investments in the surviving females. And so it is in this context that this paper asks the following questions. The first is, how does a ban on sex-selective abortions affect gender gaps in educational investments by parents? In a companion paper, we also consider the impacts on health investments. And second, what are the specific mechanisms through which these outcomes are affected? So the ban has the impact of increasing the number of female births, and an increase in female births could affect the gender gap in education in a number of ways. The first is the one to which I've already referred, which is a trade-off between the number of girls and the extent to which that they are desired by the families in which they're born. Girls that are unwanted would simply face higher levels of discrimination from their parents in terms of the resources that are expended on them. A second channel could be a pure selection effect. If the ban disproportionately affects rural households or poorer households, which are unable to, for example, to get access to private underground clinics at high expense to get access to ultrasound and sex-selective abortions, then these girls are disproportionately going to be mechanically have lower levels of education because these households have fewer resources to begin with. A third channel could be through the use of fertility stopping behavior, where households which do not have access to abortions or to sex-selective abortions in particular, will simply keep having children until they are able to gain their desired number of boys. And so girls would disproportionately be born into families which have a larger number of siblings, where they face greater competition for resources, and therefore face lower levels of investments relative to boys. And finally, there's a potential channel that kind of goes in the opposite direction, which is a marriage squeeze hypothesis. An increase in female births could generate a marriage squeeze in favor of males, which means that a relatively larger number of females are now competing in the marriage market for a relatively smaller number of males. And this could lead parents to increase investments in those areas which have a high return on the marriage market, education being one of them. So an increase in female births could lead to higher investments in the education of daughters so that they are able to make a higher quality match. So in this paper, we exploit intertemporal and geographical variation in India in the implementation of laws that prohibit the use of ultrasound technology and sex-selective abortions between 1988 and 2002 to identify first whether this ban did have any bite, did it have an impact on the probability of female births? Two, what was the impact on the gender gap in educational attainment of these surviving females relative to males? And finally, to study some of the potential mechanisms that I just discussed. In addition to this kind of standard differences in differences setup, which you're going to see, we also have a third source of variation, which is the sex of the firstborn child. So recent research has found that in India, families tend to practice sex-selective abortions not at a birth order of one, but at higher birth orders. So if the sex of the firstborn child is as good as random, then that generates variation in treatment intensity between these two different kinds of families, where families which have firstborn girls are relatively more intensively treated because they're much more likely to practice sex-selective abortions in the first place. Okay, a quick preview of the results. We do find that the ban led to a significant increase in the probability of female births of about 2.5 percentage points, and correspondingly also led to a widening of the gender gap in education. Females were 2.3, 3.5, and 3.2 percentage points less likely to complete grade 10, complete grade 12, and to enter university in treated states. We also find that there is a strong selection effect, so the effects are being driven by less wealthy households, and particularly in rural areas. But at the same time, even when we consider the effects within this limited sample, we find an increase in the gender gap in education even here. So even though we do have some kind of selection going on, there's still discrimination taking place within these families. Our paper presents what we believe are the first causal estimates of the effect of changes in sex ratios on the gender gap in educational attainment. We also provide robust evidence on the impact of the ban on the probability of female births using a different data set, a much more expansive data set. And finally, we discuss a literature which talks about the unintended and adverse welfare consequences of supply side measures that do nothing to address the underlying norms around son preference, and so do nothing to address the actual demand for sons in these societies. Okay, just by way of quick background, the rapid spread of ultrasound technology in India in the 1980s and 90s led to a staggeringly high number of abortions of females. Malhotra and Cochrane estimate that as many as 500,000 females were being aborted per year between 1995 and 2005. And so in response to the inevitably very skewed sex ratios that emerged, state and central governments in India banned the use of ultrasound technology for sex detection, and imposed very strict penalties, including prison time, large fines, suspension of licenses, and so on, both for medical practitioners as well as for their patients. The implementation of this was staggered, however. So the first state to pass such an act was Maharashtra in 1988. This was followed by a national act, which was implemented in all states other than Jammu and Kashmir, that was in 1994. And finally, Jammu and Kashmir passed a similar piece of legislation in 2002. The data we use to study this staggered implementation of this ban is from the National Family Health Survey, the fourth round of it. This was collected in 2015-16. And the main outcome variables we look at are drawn from a fertility history of all women between the ages of 15 to 49. So we know the date of birth and the sex of the child, of every single child born to all the women in the sample. And we also have the educational attainment of all household members, male and female, born between 1989 and 2002, which is during this particular period of time. So this is the first of the two estimators we run. This is a triple difference estimator that we have. The outcome variable here is whether a child that was born in a particular year was female. And we regress this on the interaction of all three sources of variation. So whether the child was born in a treated state, after the ban was implemented, and to a family with a firstborn girl. So beta 1 is our coefficient of interest. We also include fixed effects, not just for state, year, and firstborn girl, but also for pairwise interactions of all three. So this is quite a demanding specification that allows us to control for a number of potential confounders and pre-existing trends and so on. And since we have a relatively small number of clusters in our treated states, we also compute standard errors using wild cluster bootstrap method. The second estimator that we have regresses the outcome variable related to education. So in this case, we have 3 outcome variables: whether a person completes grade 10, completes grade 12, and enters university. And this we regress on the interaction of whether that person was born in a treated state after the ban was implemented, and whether the person is female, so that we can pick up the gender gap. You'll notice this is slightly different from the first specification. We do run the identical version of the first specification as a robustness check, but the reason that this is our preferred specification here is that we can't actually observe whether a woman comes from a family with a firstborn female child if she has already left the home in which she was born. So in other words, if a woman's in a marital home already, we can't trace the composition of her siblings. So we run a similar specification to the one on the previous slide for a limited sample of women who are still in their parents' home. Again, we have the full set of fixed effects and pairwise interactions between all of them. Let me move to the 2 main sets of results that we have. The first result is basically that this ban did indeed have bite and led to an increase in the number of female births of between 2.5 to 2.6 percentage points. Even when we include the full set of fixed effects, the effect just drops out when we include mother fixed effects. So that suggests that the impact is it varies across the different mothers and not within a single mother. And the second set of results that we have, which are our main results, look at the gender gap in educational attainment. So you can see that there's a significant worsening in the gender gap in educational attainment. Women are 2.3 percentage points less likely to complete grade 10, 3.5 percentage points less likely to complete grade 12, and 3.2 percentage points less likely to enter university compared to men. Including the full set of fixed effects doesn't shift our point estimate around too much. Our results are robust to whether we look at all the states or simply the border states. I'll talk about some of additional robustness checks we've done in the very next slide. We show that the estimated betas did not change prior to the ban, so we don't have evidence that parallel trends assumption has been violated. Could the ban have led to a change in women's son preference? In other words, could this ban also have demand side elements where it changes underlying social norms? We find no evidence of that either. As I said, we have a smaller sample where we are able to run the same estimator, which compares firstborn girl and firstborn boy families. And again, the results are the same. And they're also robust to using only Maharashtra and Jammu and Kashmir, respectively, as control states, considering only bordering states, and considering only bordering districts of bordering states. I'm going to be brief in my discussion on the mechanisms. We do discuss all of the mechanisms that I discussed earlier. I'm not going to show you those results, but I'll talk a little bit about what we find. We do find a strong selection effect, and anecdotally, it seems to be the case that in urban areas, there was a proliferation of these underground clinics where you could get access to ultrasound technology, and you could even get access to abortions undertaken with the sole purpose of aborting female fetuses. And so we find that the impact, the treatment effects we estimate are really concentrated among less wealthy households in the bottom half of the wealth distribution and in rural areas, because the ban's impact was much greater for them than it was for these households that were able to get away. But as I discussed earlier, even within these limited samples, we see the gender gap in educational attainment rise. So we are seeing within these families an increase in what we think is discrimination by parents against unwanted girls. We don't actually find any evidence of fertility stopping behavior. So there's no impact on fertility. Girls don't seem to be born into larger families as a result of the ban in treated states. It's not possible to directly estimate the marriage market effects on educational investments. So we look at a couple of different indicators of whether we think there's a marriage market squeeze going on. And what we look at is the age of marriage. Are girls married at the age of 15, at the age of 18? What is the age at which they get married? And the spousal age gap. And we find that, that women are getting married later. So there's an increase in their age of marriage by about half a year, and no impact on the spousal age gap, which is consistent with the existence of a marriage squeeze. So that a marriage market squeeze in favor of men. So that suggests that the effects that we do estimate are possibly mitigated by the presence of marriage market effects. In other words, it would have been much worse in the absence of these marriage market effects. And so given all of this, we think that there's a strong case to be made that there is discrimination against unwanted daughters that's likely to play an important role. Just to wrap up quickly now, efforts to eliminate gender discrimination can really backfire unless they try and address some of these deep driving social norms, because the best that they are going to do is displace discrimination from prenatal stage to the postnatal stage. This is not to suggest that we shouldn't have supply side restrictions on abortions, on the use of ultrasound technology to detect the sex of the fetus in contexts such as India, but these policies need to be complemented by policies that also target gender discrimination at other margins as well, in this case, particularly education. Okay, I think I'm just out of time there, so I'm going to stop here. Thank you very much.
Thanks so much, Anisha. You make my job very easy. So just welcome to those who've joined us more recently. The chat at the bottom, you can put in Q&A questions throughout the whole time. So as a question occurs to you, please type it in. And in the last 20 minutes, we'll come to all of the questions. Thanks so much. So now over to Gabriela. She'll be talking to us about gender norms, violence, and adolescent girls' trajectory, evidence from a field experiment in India.
Thank you very much, Claire. The work I'm going to present today is joint work with Alison Andrews, Sonia Krutikova, Abhishek Gautam, and Hemlata Verma. As you all know, there are striking gender inequalities that persist across key dimensions of human welfare, and these are especially more salient in low middle-income countries. Of course, there is potential for improvement through the process of economic development. However, we have to take into account that there are important contextual and cultural factors that can really perpetuate the gender gaps that exist. There has been a lot of policies targeting women specifically, considering this, for instance, policies related to women's legal rights or cash transfers. However, the impact of these policies might be undermined if we don't take into account and if we don't address the norms context. Motivated by this, we study the potential of targeting norms and attitudes directly to achieve improvements in key outcomes for adolescent girls. And these outcomes can relate to, for instance, education and marriage. In this research, we're going to think of norms in a really broad sense. We're going to think of them as informal rules that govern what is seen as appropriate behavior. And we are going to analyze the impact of two interventions. The first intervention is called the girl group intervention, and this consists on a series of education and sports sessions in which girls will discuss about topics related to the origin of norms, their rights, among other topics. There is also a second intervention that is called the community engagement intervention, and in this one, in addition to the sport and education sessions, we engage the community. So girls and the community will discuss topics around the challenges and constraints that girls face in the community. As a quick preview of our findings, through our research, we're able to find that these interventions are able to increase the probability of staying at school by 20%. They also reduce the likelihood of early marriage. And we also find that in the community engagement arm, there are substantial improvements in mental health. And I will talk more about this later. With respect to the contributions, our research contributes to mainly three streams of work. First of all, the research that has been, that already exists related to what are the effects of other programs that target gender norms and attitudes, and if these programs also achieve changes in behavior. The second stream is related to the new evidence with respect to the well-being costs and benefits from actually deviating from these norms. And finally, through our research, we're able to compare the efficacy of targeting different actors, as we don't only focus on girls, but we also focus on the wider community. With respect to the context, this research is focused on northern India, in Rajasthan, in rural Rajasthan, in the Dholpur district. And I would like to highlight mainly two things of the context in this area. First of all, that there is a great need for improving women outcomes. For instance, in this plot, we are able to say that we are able to observe that in Dholpur, the early marriage rate is much higher relative to the national average. We're also able to observe that and the proportion of women that have more than 10 years of education is much lower in Dolpur relative to the national average. A second thing that is very important to keep in mind is that norms in this context really influence girls' decision. With these norms, they really face also mobility restrictions, and they face also limits in terms of how they interact with the outside world. For our data, we were able to collect information about the norms and the agreement to norms of girls and their caregivers. Here I present few of the statements and norms that we evaluate through our data. For instance, with respect to girls' mobility, we observed that 70% of the girls agree with the statement that says that after menarche, girls should not be allowed to go alone in the public space. The data also allow us to observe that the girls perceive that there are risks related to violence when they actually break certain norms. I also wanted to highlight that this is a context in which girls have high educational aspirations. However, they are not able to achieve these aspirations. In this plot towards the right, we observe that when we ask the caregivers what are the main reasons why girls can't continue education, one of these reasons, for the 80%, they say that it is because the secondary schools are located too far. And this is important to mention because the fact that the school is too far generates two effects. First, that girls will need to walk alone or go alone to a school, and also that they might have to use gender mixed buses. And these actions that they might take really might influence or have a relation with the norms that they will have to break to be able to continue a school. Having this in mind and this context in mind, we come up with a simple framework to try to analyze how can programs contribute to change norms or to change the costs from deviating from norms. The overall idea that we have to keep in mind here is that girls and their families will have to make decisions. For instance, decisions on whether to continue education or not. And this goes in line with taking decisions of whether they have to break gender norms or not. And they will make these decisions taking into account two main components. First, their own preferences over schooling, as well as preference related to certain actions that they will have to take to attend a school, like for instance, traveling alone on a bus. And another component is that girls also have to take into account that there are external costs of punishments that they might face if they break some of the rules that are imposed from the wider community. Taking this general framework in mind, we design an intervention that has two treatment arms. As I mentioned at the beginning, the first program is the girls groups, and the aim of this program was to improve girl outcomes through targeting norms. And the aim was to increase girls' subjective valuation of schooling or attractiveness to schooling, and also reducing the weight that girls place on what the wider community thinks. This intervention consisted on doing education sessions. In these education sessions, the curriculum covered a series of topics, including the origin of norms, the decisions around the timing of marriage, what are the rights of girls, the importance of education, and also topics around violence. In addition to these education sessions, we also offered, they also were involved in weekly sport sessions in which girls were using the public space to play kababi, something that was not really common to do before the intervention in these areas. The second program is the community engagement program. This program has the goal of also targeting girls' attitudes and behaviors, but in addition to this, the goal is to also target the restrictive external norms that exist in these communities. For instance, by reducing the severity with which girls were punished for breaking norms. To achieve this, in addition to providing these education and sports sessions, this specific treatment arm was offering community campaigns in which the girls and their community was meeting together to discuss different topics or sensitive topics regarding, for example, the mobility of girls in the community or the restrictions that they faced and the challenges that they faced in the community. To evaluate the impact of these two interventions, we ran a 3-arm cluster randomized controlled trial across 90 villages, where 30 villages were assigned to the girls group, 30 villages to the community engagement group, and 30 villages to the control group. All the intervention was implemented by an NGO, a local NGO called Pradam, that already had access to these communities in the study areas. And all the activities were facilitated by trained mentors, female trained mentors that were between 19 and 25 years of age, and that they belong to the study communities. With respect to the sample, our sample is composed by young girls between 12 and 17 years of age that were unmarried at baseline. And our sample strategy allows us to analyze different girls' outcomes for 2 strata, girls that are between 12 and 14 years of age at baseline, and also girls that were between 15 and 17 years of age at baseline. Our attrition is uncorrelated with treatment status, and baseline characteristics are balanced over the 2 treatment arms. With respect to the estimation, we run a standard specification. We are going to run an OLS when we have continuous outcomes, in this case related to mental health, and a logistic model when we have binary outcomes, in this case, for example, schooling and early marriage. Our errors are clustered at the village level, that is our unit of randomization, and we estimated p-values adjusting for multiple hypothesis testing. Before showing you the results, keep in mind that these are intention to treat effects, and also that these are the results that come from a 3 months follow-up. In this table, I'm showing the results for the schooling and marriage outcomes. And the results are split in 3 groups. First, we show here the results for the older girls. Here in the next 2 columns, the results for younger girls. And finally, we observe the results for the pooled sample. Let's start with older girls. For older girls, we can observe that there was an increase in the likelihood of staying in a school that is by 6 percentage points. It's a similar effect size for both treatment arms, and this corresponds to an increase on around 20% relative to the control group. With respect to marriage, we observe a decrease in early marriage of around 3 percentage points. It's of similar size between 2 treatment arms, but it's only significant in the girls group intervention. When we pull the sample together, we observe that the effect size is smaller. And this is mainly because the results are driven by the older girls that are also the girls that might be facing the highest risks with respect to dropping out or getting married earlier. Also, it's important to mention here that we run some mediation analysis that allow us to explore that the marriage effects are mainly driven by the schooling effects. And this is mainly a correlation analysis. With respect to mental health, first of all, I would like to say here that we use 2 scales that are widely known and that have been validated in different contexts. And these 2 scales we also pilot before the end-line data collection, and they refer to the PHQ-9 to measure depression and the GAD-7 to measure anxiety.
Gabriela, just a 2-minute warning.
Thank you. And across the board, what we observe is that there are improvements in mental health, and that what is very interesting in our findings as well is that these findings, these improvements in mental health are mainly driven by older unmarried girls currently attending schools. So the girls that could be it's more likely that we're in conflict with pre-existent norms. Very quick in terms of the mechanisms, just to say that when we relate these to the conceptual framework, what we find is that These effects might be related to the fact that the schooling effects might relate to the fact that there is an increasing in the preferences towards schooling, toward the evaluation for schooling. But with respect to the effects of mental health, it's possible that this reflects to the fact that we also observe that there is a reduction in patriarchal views among the girls that are 15 to 17 years of age in baseline, but only in the community engagement arm. And we also observe there is a lower perceived likelihood or fear of violence when they break norms among girls that are between 15 and 17 in baseline, and also only in the community engagement arm. So these changes in norms that are mainly seen in the community engagement arm might be driving also the effects we observe with respect to mental health. And just to conclude, three main things to keep in mind is that through our intervention, we're able to show that that it's possible to work in context with highly restrictive norms, to target these norms, and to be able to actually see improvements in the outcomes of girls. That is also important not only to target girls, but the wider community in general. And we also don't find any evidence that the well-being of girls was affected when we encourage them to question the norms in the community. Thank you very much.
Thanks so much, Gabriela. So just a reminder to anyone, feel free to type in your questions in the Q&A box and we'll get to them at the end. And now we're handing over to Ahmed Elsayed to speak to us about the women empowering effect of higher education. So if you can share your screen.
Can you see it? Perfect. Good. So thank you, Claire, and thanks everyone for joining today. So this paper is joint work with Alina Shishikova, who's a PhD student at Maastricht University. And in this paper, we study the impact of university construction on education outcomes, labor market outcomes, and marriage outcomes in a context of low economic and social empowerment, which is pretty much the Middle East and particularly Egypt. Why this topic is important? Well, we all know that there are gender disparities in education, which still persists in several developing countries, despite the fact that there has been considerable improvements over the last decades. This is pretty much related to the issue of male bias, which links gender inequality in education and economic development. This graph, for example, from the paper by Jayashandra in 2015, shows a negative correlation between GDP per capita and the ratio of female to female tertiary education. And as you can see, there's like negative correlation between the two variables. And we can pretty much replace this ratio in tertiary education with any other education disparity indicator, and you'll find pretty much the same picture. Why this is the case? There are two reasons for this. The first one is expected returns for girls are usually lower because most of the families believe that boys are going to support us at old age while daughters are getting married and leaving the household. And the other thing is relative costs. And costs is not only financial costs, but also costs related to social cost and stigma. So it's a little bit difficult to send my daughter away to get education, while it's easier relatively for my son. And this explains why education policies, even the gender neutral ones, benefit girls more. Despite the importance of higher education, there's not much evidence in the literature on this topic. And the reason could be that the perception is like this type of education is for the elite, but also it's the type of education that opens the door for high quality jobs and opens the door for social and economic empowerment. So what we do in this paper is we investigate the impact of higher education on labor and marriage outcomes. And the identification strategy comes from the expansion of higher education through constructing public universities in Egypt after independence in the 1950s. So over the time period 1960s and 70s, the policy of higher education back then was to build a new university in each province. So a total of 16 universities were built over this time frame. These new universities reduced the cost of attending higher education for the two genders, but pretty much for women who were previously constrained with social norms to go away. What we do here is we combine data on the time of university opening within provinces, together with individual data on education outcomes, and later in the future on measures of labor market outcomes for the two genders from the labor force surveys, and marriage and social empowerment of women from another dataset called Egyptian Labor Market Panel Survey. This is the map of the country. And as you can see that there's like a staggered rollout of university construction across the country over this time frame. We exclude, of course, like the big cities, Cairo, Alexandria, etc., which had universities longer time ago. We also exclude the war-affected governorates or provinces, those ones, which were affected by the war between Israel and Egypt over the time frame 1967 till 1973. If we look at the others, you'll find like, staggered rollout of this, which we make use of to study the impact of higher education. What we find in the paper is, as expected, positive impact of higher education expansion on university education. Opening a university in a province increased the probability to get higher education by about 1.6 percentage points, which is around 10%. But the impact is mainly driven by women. So 4 percentage point increase, which represents about 35%. And the reason is like, they were previously constrained by social norms, which hindered them from getting education at distant universities. We then find longer term positive impact on labor market outcomes and marriage outcomes and social empowerment for women within marriage. The data used in this exercise are coming from three main sources. The first one for university construction. In Egypt, each public university built comes with a presidential decree. So we get like, the presidential decree with the exact time frame when exactly it was constructed, and also the characteristics of the university in terms of like size, etc., and the exact place. Also, the official website of each university provides a lot of information about the history of the university, because when they construct a university, it's not constructed right away. They start with 1 or 2 schools, and then, they keep on expanding. And the third source is the data set on International Association of Universities. Then the second source at the individual level is the labor force surveys between 2007 and 2016. It's repeated cross-section with a total of 120,000 observations. The majority are men. It contains a lot of information on education attainment and labor market outcomes. The third source, the advantage of this one is like, it has a lot of information on the education and labor market, but it doesn't have a lot of information about historical background of the family. So I don't know who actually came from richer households, etc. This happens here in this other data set, the Egypt Labor Market Panel Survey, which collects a lot of information on marriage outcomes. So we use this one also to study the impact on social outcomes. The empirical strategy is pretty much staggered definitive. We regress the outcome of interest, which could be education related, labor market related, or marriage related, for individual I, province R, and K cohort of birth, on a dummy variable that indicates if the individual belongs to the exposed group, meaning that she was 12 to 18 years old when the governorate or the province got access to higher education. In other words, when the university was constructed for the first time. X is a vector of controls, pretty much due to the nature of the data, 2 variables, urban versus rural and gender. And then we also control for governorate and cohort of birth fixed effects and the interaction of those two to control for differences in education trends within provinces. And then we have an error term. The 2 main assumptions here are, first, there's no selection of individuals into treatment, right? So if treated and untreated individuals are different on observable or unobservable characteristics, then any effects we could find could be pretty much not causal and driven by some other characteristics, right? But what speaks against this is the fact that this kind of intervention is at the province level. So it's like public university built by the decision of the central government in Cairo. So it's beyond individuals' control. So it could be, there could be like, some selection or like, which governorate or which province to start with, but this is beyond your control. All what you can do is to migrate, right? But I'm going to show you that migration doesn't play a big role in this. Actually, migration is very low in Egypt. All in all, 2% migrated ever in their lives. And actually, we, as Robustus Check, do a lot of regressions controlling for migration, but also like doing this for people who ever migrated versus those who didn't migrate. Also, we play around with neighboring and neighboring governorates, neighboring provinces, and we find no impact actually of building a university in the neighboring province. The biggest challenge is this one, or the biggest assumption is like, there should be no pre-trend within governorates in education prior to the construction of the university, because then the impact could be driven by some other patterns prior to the construction of the university. To deal with this, I'm going to show you this graph, which pretty much regresses the change in probability to finish higher education for the different cohorts of birth, right, around the time when the university was built. This is the age when university opened. So those are the older cohorts, and those are the younger ones, right? And this is the age of starting university, like ET. And as you can see here, prior to building a university or constructing a university, there was nothing, right? And then it starts to kick in here at the age of 18. So for the younger cohorts, actually, they are more likely to get education, higher education, by the fact that, a university is close by. And most of this impact is driven by women, not by men. Men witnessed also some increase, right? But not as massive as women. So actually, this graph tells us like, there's no pre-trend to begin with, but also there's a positive impact of building a university in your governorate. The second one that speaks about the selection at the individual level is this balancing test, where we regress the treatment on a bunch of observable characteristics that we have. We don't have that many. One time without controlling for the time trend and governorate fixed effects, and one time after controlling for this. So here you find some selection actually for some characteristics, right? But once you control for the time trend and the governorate fixed effects, this disappears. So the assumption here is like, there could be selection on who's treated, who's exposed, and who's not on observable characteristics. But given that we are doing this within governorates and controlling for the time trend, most of this is taken care of. So let me show you some results for the education, labor market, and marriage. This is education for the whole sample, women and men. As you can see, that there is a positive impact actually for the whole sample, but it's pretty much driven by women. So this is an increase of 0.6 percentage points, which is around 11% on average. For women, it's an increase of 4 percentage points, which is 35 or almost 36% increase. For men, there's a positive impact, but it's not statistically significant, right? When we look at the labor market outcomes, the longer term impact of the policy, we find positive impact for women, mostly on the margins of paid jobs. You can see here that, to start with, only 23% of women had paid employment prior to the policy, and this increased it by 3.7 percentage points, which is about 16%, right? The same applies to formal employment, public sector job. On the intensive margin of working hours, etc., there's no much happening here, also in terms of wages for women or high-skilled jobs. But for men, there's a bit of positive impact on wages, returns to education, and the probability to be in a high-skilled job. Then marriage outcomes, which comes from a different data set. To begin with, we did this regression for the university degree just to make sure that we get comparable coefficient, and it's pretty much similar. So this is 3.7 compared to this one, which is 3.6, 3.9, pretty much the same. Age at marriage was not affected, but husband's years of education increased massively by 1.5 years on average, which is an indicator of better quality of marriage. And then also another indicator is intra-household decision-making, which is a series of questions asking about who's making the decision in different scenarios within the households, like different 10 items, asking like, in each of these following scenarios, who's taking the decision? You alone, you together with your husband, or your husband alone, right? And we get like a dummy if the woman is making a decision in each of those, and then we have an index out of these 10 items. As I mentioned, this is robust to several checks, including, for example, different levels of clustering, including also accounting for possible negative weights, because we are using two-way fixed effects here, controlling for the governed rate fixed effects and the year fixed effects.
2-minute warning, Ahmed.
Perfect, okay. Also, it's robust to migration, and it's robust to including never treated provinces. So far, we have been focusing on the governed rates or provinces that witnessed university at one point, but also it's robust when we include the others that never witnessed university. So the conclusion so far is there's positive impact of university construction on university enrollment and finishing higher education, especially among women in Egypt. There's long-term positive effect on labor market and marriage outcomes and social empowerment for women. Next steps would be to look at the impact on STEM education, because as I mentioned, when university opens, you start with one school or like two schools, and there could be variation actually in what type of school you're talking about. The second one is to expand the exercise to other countries and create kind of a global database. Thank you so much.
Thanks so much, Ahmed. So on to our final presentation now. Over to you, Gertrude, to speak to us about Can Schooling Reduce HIV Stigma? Evidence from Zimbabwe.
Okay. Thank you, Claire, and thank you everyone for attending this conference. I'll be presenting.
Sorry, Gertrude. Oh, sorry. Would you, sorry, Fiona, would you mind going to full screen?
Okay.
So we can get the full effect. Thanks so much.
All right, sorry about that. I'll be presenting on the paper titled Can Schooling Reduce HIV Stigma? Evidence from Zimbabwe. So as you may be all aware that HIV rates have been relatively high in sub-Saharan Africa. And as of 2018, about half of the HIV infected persons were living in sub-Saharan Africa. And there have been a lot of efforts to try and reduce the infection rates in the region. But stigmatization of people living with HIV and AIDS has also made it more difficult to reduce these HIV infections in the region. Why do we care about stigmatization of people with HIV? Stigma can actually deter people from getting tested, seeking treatment, participating in HIV educational programs, that is, say, mother-to-child transmission programs, or practicing safer sex methods and the use of condoms in this case, or even sharing their HIV status with their loved ones. So education has been proved to have a positive impact on quite a number of health outcomes, that is, say, life expectancy and other mental health issues on adult health outcomes. But just a few papers have looked at the effect of education on HIV-related outcomes. And given the magnitude of the HIV and AIDS epidemic, as well as persistently high levels of stigmatization around the disease in sub-Saharan Africa, there is quite a need to better understand the role that schooling might also play in reducing the spread of the virus in the region. Hence, this study tries to investigate the connection between educational attainment on HIV-related outcomes. But in this case, we are not only focusing on HIV status and testing, but we are also trying to look at the effect of education on negative attitudes towards people living with HIV and AIDS in Zimbabwe, as well as women's ability to negotiate safer sex practices and resist domestic violence in Zimbabwe. So why women? Women in developing countries are more vulnerable to HIV infection and have less ability to negotiate safer sex practices, and yet they are the key determinant of the future generation of HIV status, that is through mother-to-child transmission, and the ability of women to negotiate safer sex practices with their partners and disapprove of domestic violence thus plays an important role in protecting women from HIV. So the main research questions of this study are, can schooling change the attitude to HIV stigma and reduce HIV infections? Does formal education enhance women's ability to negotiate safer sex practices and resist domestic violence? And we also try to provide other mechanisms, which I will talk about later in my slides. So the main challenge in trying to analyze this effect is the issue of endogeneity in terms of education. We may not be able to observe some of the factors like family background, women's preference, and community characteristics. So we are going to take advantage of the educational reform that was implemented in 1980 in Zimbabwe. That kind of created a natural experiment to test the causal link between education and HIV-related outcomes. This is not the first paper to have done so. There are quite a broad literature that have used a number of education reforms, such as free primary education, and we are also trying to follow suit in this paper. And also, given the historical background which favored sending boys to schools rather than girls in most African countries, including Zimbabwe, we would expect this reform to have benefited girls more than the boys. So the main contribution of this paper is, this is the kind of a first study to be conducted on the effect of the education on HIV stigma in Zimbabwe. And also, so far, we are only aware of one paper by Tsai et al., which was conducted on Uganda, and they found no effect of education on HIV stigma. But Uganda and Zimbabwe are quite different in terms of their HIV infection rates. Zimbabwe is quite high in terms of its HIV infection rates and HIV stigma. Hence, their finding may not be the same in the context of Zimbabwe. So we are trying to conduct a study in a quite HIV-infected region, country, and also with a high HIV stigma rates. Then this is amongst the first few studies that examine the effect of education on HIV status and testing. There's a paper by Alguero that also looked on the effect of education on HIV knowledge, and they tried to touch on the effect of education on HIV status and testing, but they didn't find any effect, and we are trying to update on this issue. And we are also trying to complement other studies that have looked at the effect of education and female empowerment. So the reform itself, it comprised of about 4 elements. That is the free primary education and the removal of age restriction on school entry and encouragement of community support for education. That is where the community people were encouraged to support in terms of building the schools and also in terms of financial support to build the schools, because there was massive construction of schools around that time. And there was also automatic grade progression, that is from primary to secondary. And the reform allowed every child who was primary
let's just go to our very exciting Q&A
to benefit
session
from
now.
The policy. And in terms of the school entry age in Zimbabwe, it's age 6, and we expect children to leave primary school at the age of 13. Hence, the policy also allowed children who had dropped out of school to rejoin school. So we expect the policy to also have affected the school quality. That is, the pupil-teacher ratio kind of increased around that time, but the government tried to cater for this by training a lot of teachers and also using multi-shift system. We are using DHS data, the last 4 waves of DHS data. And just to clarify on this, the last 3 waves of data, that they contain the HIV actual testing, but the 1999 data set, we're just using it for other outcome variables. And I will not go on to define the variables that we are using, but in terms of HIV stigma, we are using the definition provided by DHS report, where they define someone as having HIV stigma if they show any signs of stigmatization in about 5 questions that were being asked during the survey. And the sample that we are going to use, it comprises of women who were aged 6 to 21 years in 1980, and those who were 6 to 13 years are our treatment group, and those who were aged 14 to 21 are our control group in this case. And the total observations are 8,633. So just to also check, since I said that the school entry age is 6, and we expect these children, the girls, to have left primary school by the age of 13, just to try and check the proportion of girls who were still in primary school at each age. We note that at age 13, quite a high number of girls were still in primary school, but after age 13, we see that a few of them were still in primary school at the age of 14 and ages 15. So we are going to try and talk about this later on as I present. Then in terms of our model specification, we are implementing a fuzz regression discontinuity, and we are estimating these 2 equations where we are estimating the where Y is our outcome variable and E is our years of education in this case, and F is the forcing variable and Z is the instrumental variable, where Z is equal to 1 if someone was born after 1967 and 0 otherwise. So our coefficient of interest is beta 2, and the identification assumptions in this case is that there was no manipulation of treatment status, and the exclusion restriction assumption holds. So we tried to test for these assumptions by using the methods that were suggested by Imbens and Limax, and by actually performing the Macquarie test and Catenary test, and we found that the DC density was quite smooth at the cutoff, although I didn't provide this graph, this figure in this presentation. And also we tried to test the predetermined characteristics, and we realized that they were quite smooth at the cutoff. So in terms of our results, we noticed that this is the graphical presentation of our results. We noticed that women who were born after 1967, they had on average more years of education compared to women who were born before 1967. And they were also on average having more chances of attending primary school compared to those who were born before 1967. And the actual result,
5-minute warning. Sorry, Gertrude, just letting you know.
And the actual results shows that being born after 1967 increases your years of education by 1.26, and also the chances of attending completing primary school by 20 percentage points. So in terms of our main outcome variables, we find that a year increase in education reduces the chances of being HIV infected by around 4.5 percentage points to 5 percentage points. And we also noticed that a year increase in education reduces the chances of having negative attitudes towards people with HIV by, sorry here, I didn't put a negative here, by negative 2.3 percentage points to around 5.3 percentage points. So the mechanisms here, the main mechanism through which education might have affected the negative attitudes towards people with HIV is through comprehensive knowledge of HIV. And we noticed that a year increase in education increases the comprehensive knowledge of HIV by 6.4 percentage points. And the rest of the other mechanisms here, they are trying to explain the effect through which education might have affected HIV and AIDS status. And mainly they are to do with female empowerment in terms of reducing their years of education gap between the husband and wife, and the age at marriage and age at sex. And also its education improves their safer sex practice methods, and also reduces the domestic violence by around 7 percentage points. Sorry, I to rush through. I am not really presenting much on those ones. And before I got on to my conclusion, we performed quite a number of robustness checks to our results, where we excluded those children who were partially treated. Those were aged around 14 and 15 years. And we still found that our results were stable. And we also tried to compare the fully exposed cohorts, because here I was comparing the partially exposed cohorts vis-a-vis the non-exposed cohorts. So we tried to compare those who were fully exposed and those who were non-exposed, and we still found that our results were quite stable. So in conclusion, I will say we have shown that in the case of Zimbabwe, female schooling is a causal impact on HIV status and stigma. And we also provided the mechanisms through which education might have affected HIV status and stigma. However, we could not find any causal relationship between education and HIV testing.
Thanks so much, Gertrude. And thank you, everybody. So now we can switch to the questions. So we've got about 20 minutes of questions, and we'll first do one question for each of the panelists, and then we'll come around again if there's more time at the end. So the first question that we had, oh, and I'll call out your name and then ask you to ask the question as well, but just let us know if you don't have a microphone that's functioning and we can read it out for you. Oh, and Gertrude, could you stop sharing your screen as well? Thanks very much. Okay, so first question, Victor, you had a question for Anisha. So Victor from CSAE.
Thanks a lot, and thanks a lot to all the panelists for this great presentation. Anisha, I had a question about whether you find other effects on other outcomes such as nutrition, BMI, or household education expenditures for girls. Thanks a lot.
Hey, thanks for your question. So we actually have a companion paper that I've written with a colleague of mine that looks at specifically the health outcomes of this specific legislation. And the reason it's in a separate paper is because the health data for children is set up in a very, very different way. And so we find impacts on mortality, so neonatal mortality, infant mortality, and under 5 mortality. We link that to anthropometric outcomes such as height for age and weight for age, as well as parental investments. Unfortunately, we don't have expenditure on either education or health, but things like duration of breastfeeding, the number of visits that you make to the local health center during pregnancy or just after pregnancy, and the vaccine schedules completed for children. And in each of these cases, we find a worsening of the gender gap. So women, girls are falling further behind boys in treated states. So to answer your question, yes, we do look at a bunch of other estimates, and the story is really quite the same across all of these different measures.
Thanks so much. So Estelle from the World Bank Gender Innovation Lab, I'm going to hand it over to you to ask your question for Gabriela.
Thank you, Claire. Thank you, Gabriela, and everyone for the great presentation. So I was wondering, actually, the community engagement intervention. So if you actually look at other impacts, so for instance, on attitude of other community members and our behavior actually related to violence against girls and women. So I was just wondering, actually, how do you reconcile these assumptions about a change in attitude and norms in the community to a change in the health, mental health of girls? Thank you.
Thank you very much, Estelle. And that's a really good question. What we are able to observe in the data is that when we measure during N-line the scales related to gender norms, we do observe that there has been a reduction in patriarchal views among the girls, among the older girls in the community engagement arm. So the arm where the community was also involved in the activities of the program. And also the girls, through the data we collected, that the girls also responded a series of questions regarding what are the perceived risks of violence in specific situations. And all of these are situations in which the girls might be violating a specific norm, like for instance, walking home alone or walking with a boy around the village and different norms. And when we also measure an indicator related to this likelihood of violence reported by the girls, and again, these are perceived risks, we observe that in the community engagement arm, girls report a lower, they indicate or that they perceived lower risks of violence in the community engagement arm. So that makes us consider the fact that perhaps thanks to the community engagement arms, they now feel that the wider community is also aware of the different challenges the girls face, and they also perceive this as a way in which the girls consider they would be faced, no, they will not face no longer like the punishments for breaking certain rules, or they will have to support the communities, for instance, regarding, for instance, walking alone or things related to this. So this is mainly assumptions that we have, and we also have to run some more mediation analysis to really find the more direct connections between these and the outcome of mental health. But so far we use this as suggestive evidence that maybe these are the channels through we are able to observe these mental health outcomes. I hope that answers your question.
Thanks a lot, both. So over to the question for Ahmed from Antonio Campos from the Ministry of Ed in Peru.
So we're going to transition to questions
Antonio,
now,
are you able
and we've
to
had a good
unmute
number of
yourself,
those
or
come
otherwise
in.
I can read your question. Yeah.
Perhaps just go for it, Claire.
Alrighty. Oh, I can see you're unmuted. Speak over me, Antonio, if you need to. Otherwise, I'll read it out. The coefficient of age at marriage is large, but not significant. Do you have any additional explanation or analysis for it? On the other hand, have you considered including the birth of the first child as an outcome variable?
Sure. Thank you so much, Antonio, for these interesting questions. I don't have an explanation, but we can try several things, including, for example, early marriage, like having a dummy variable instead of having the continuous variable of marriage, for example, to see actually if this kind of expansion in education reduced the probability of early marriage, which is like a big issue. Also, the data set has a wealth of information about fertility and other aspects of social empowerment. So definitely we can try several things around these lines. So the point is well taken. We'll do this. Thanks a lot.
Thanks so much. I'm going to abuse my position as chair and ask Gertrude my question for her. So Gertrude, could you, I may have missed this, but could you tell us a little bit about what the curriculum was, if there was one for HIV? Was there an abstinence focus or a safe sex focus? Because I guess it could have gone either direction depending on what that was. And then I guess an implication of that is, do you have a sense of whether expanding education is sufficient for reducing HIV stigma, or if like curriculum, just like a short curriculum, could achieve the same thing?
Thank you, Claire, for that question. The curriculum did not include any HIV-related issues before 1980 up to around 1992. So these women, they went to school prior to the coming in of HIV issues in both primary and secondary education.
Cool. And I guess, do you have a sense of whether I don't know, you know this literature very well, of whether like an HIV specific curriculum, whether it's like abstinence or safe sex, has the potential to, have you seen similar kinds of outcomes on reducing stigma from those kinds of programs? So that's it's not directly on your paper, so feel free to pass on that question.
I never really paid attention to that because we kind of ruled out that possibility since the curriculum was not really including these aspects at that time.
Fair enough, just asking for my own selfish research purposes. Great, so I'm going to go ask another question for Gabriela that we have from Duncan Webb, who I will ask the question for him. Is the effect on schooling among the older girls driven by reduced absenteeism or by reduced dropout? Are you able to distinguish?
Thank you very much. To measure our outcome of schooling, it's based on a questionnaire we do in the questionnaire that asks if the girls are currently attending a school. We also have data related to the number of days that girls have missed school. But to be able to also talk about dropout, I think we will also need to understand if the girls that responded in the survey that they were currently attending school, if those that were not attending school at the time of N-line are planning to go back to school. Currently we can't analyze that, but we're planning to, this year we're going to do the 3 years follow-up. And I think with the data that we collect here, we are going to be able to respond better dropout, for instance, with more precision. Thank you.
Thanks, Gabriela. Great, so over to Jen, who has a question for Gertrude. Jennifer, sorry, from CSAE.
Thanks, Claire. Thank you, Getrude, so much for the interesting paper. I had a question around how the comprehensive sex education was delivered. If you had any data on the age and gender of the teachers, and if you looked at the effects of that, if maybe younger teachers had, there were greater effects by younger teachers, because there's some education on, there's some research on the effects of peer educators. So I wondered if you looked at that as well.
Oh, okay, thank you very much. I think the question is also kind of related to what Claire has just asked me to. The only thing that I can say, I will not completely rule out those possibilities, but since sexual education was kind of not talked about in schools before 1992, it's only after 1992 that's when these discussions were being conducted in schools. So these women, they were born around 1959 to around 1974. So they went to school prior to this kind of education being conducted in schools. So I am not saying there was no possibility of that, but I kind of feel that it's kind of ruled out.
Thank you.
Great, and now I'm going to ask one question of Ahmed, and just in the interim, I'll also remind the panelists that you are also welcome to ask each other questions, so feel free to put it in the chat or to raise your hand and I can come to you afterwards. So my question for Ahmed is, so there's a study from 2018 in AEJ looking at the effect of increasing secondary education, I think for girls and boys, and found an increase in, I think, psychological domestic violence. Just curious if you looked at domestic violence impacts of your intervention.
Unfortunately, no. And unfortunately, I don't think actually we have data on this, given that it's a super sensitive question. So actually the data that focuses on social empowerment aspects come from a representative data, Egyptian labor market panel survey, and they ask the household a lot of questions. So I doubt actually, but it could be the case that they ask people about their attitudes about about domestic violence. Like this could be like, at least like, something that goes in this direction. So yeah, it's worth looking at. But there are also some other aspects related to mobility, like, if women are totally free to go outside without permission, this kind of stuff. What else? The intra-household decision-making, the one I showed. Yeah, I'm not sure what else. Could be some aspects on attitudes towards domestic violence. Yeah.
Cool, thank you. Okay, I'm going to abuse my power again and ask Gabriela a question. So Gabriela, given you say that the main channel for your intervention working is through norms, I was just curious, given a lot of other norms-focused interventions working with adults have not found much impact when they're really tight, short interventions really focused on norms. So I was just curious if you had a sense of how to reconcile that. Is it because your program is working with adolescents, you think, or that it's really intensive? So it's like I think I read 14-month kind of intervention. So it's actually hitting a lot of other things. Just curious how you see it fitting in there. Thanks.
Thank you, Claire. I think it can be related to what you have just mentioned. This is a 14-month intervention where the girls have weekly sessions in which they constantly discuss topics that are really sensitive, and they don't have any other setting where to discuss this. So this is really a kind of a unique opportunity for them to talk about things that they don't normally talk about within the households or in the schools. So maybe this makes it different to, or this already makes it different to other settings, referring to the projects that maybe you're mentioning with more related to adults. So I think that could be an important difference, and the specific context in which these girls are growing up, these adolescent girls. So I think the answer could be related to that. And well, the fact that we also observed that a lot of the impacts in the community, of changes in norms in the community engagement arm, I think also shows the importance of involving the community in this for the girls to perceive, to benefit from this intervention even more. But I think it's related to what you're mentioning.
Thanks a lot. And I'm just going to be very sneaky and do a couple of follow-up. So I guess curious about why the program doesn't work with boys, given that's who girls will marry, I guess. And so that matters. And then if you look at role models and like, because obviously 14 months, you said the people doing the intervention are like 50, I think like young women, like 20 in their early 20s. Do you look at like the potential for that kind of thing?
So regarding boys, originally at the beginning, there was an idea for the community engagement arm to be really focused on boys as well and the parents, but then we realized it was going to be better to focus on the overall community. So we are not focusing specifically on boys, also because of concerns related to compliance of only boys or only, for instance, parents. So that's why we are considering the wider community. But there are other interventions in other settings that are focusing on boys. In ours, we didn't. And the second question that was related. Oh, Claire, you have to help me. I forgot.
No problem. Let me see, go to my list of questions. Role models and like sport and mental health and like other channels. Yeah.
Of course. So we analyzed at some point if, for instance, there were differences in the attendance of girls to the intervention, taking into account the characteristics of the mentor or things like this, considering that the mentors can be viewed perhaps as role models. But we don't see much differences on this. But for the follow-up, it would be interesting to think more about the role models and see if there is a way to incorporate that to the analysis. But so far, that's what we have.
Thanks so much. Great, and I'm going to call on Sri Lakshmi Papaneni from the World Bank Gender Innovation Lab. Sri, can you unmute and ask your question for Anisha?
Thanks, Claire. Thanks, Anisha, for the presentation. I just wanted to ask the policy implications of your research. Just, kind of politically charged to say, you know, the ban on ultrasound. You didn't say this in your concluding slide, but like the ban on ultrasound had some kind of impact from that. But have you thought kind of just generally on a policy side to your results?
Thanks. That's a great question. I think there's certainly a lot of attachment to the specific restrictions, particularly on revealing the sex of the fetus that exists in India. So you can't actually find out the sex of a fetus if you walk into an ultrasound clinic, right? And there's a lot of attachment to that for obvious reasons, because there's such a skewed sex ratio in parts of this country. But I appreciate that this obviously has important welfare consequences in terms of increasing the number of female births. I would just say that if we want to prevent this kind of effect of displacing gender discrimination to other margins, I think more attention needs to be paid to actually shifting the underlying social norms. So one recent government policy that tries to do that was implemented around about 5 years ago now. It's called the Beti Bachao Beti Padhao program, which is like educate your daughter and save your daughters. And that tries to actually address some of these drivers of son preference, to try and create a perception that females have worth, and that it's a good thing to have a daughter for such and such reasons. There's a huge media blitz. They roped in a lot of celebrities and so on. And so the jury's still out on how well that has worked and so on. But unlike policies that just affect the supply side, I think having something that tightens up implementation of these kinds of bans on abortions and so on, but supports them with trying to actually change the underlying social norms is really important. In the absence of that, you're just going to have to design piecemeal approaches to try and get girls into school on the one hand, and then something else to address neonatal mortality and health investments being lower as well, while at the same time pushing forward with the supply side restrictions. So it'll be interesting to see whether this kind of shift of social norms works. Of course, as Claire pointed out, this is hard to do. It's easier to implement bans in a sense, but I think the hard work needs to be done at some level. Otherwise, we're just going to see this kind of displacement effect.
That's great. Thank you.
Thanks. And then one last question from Trifina. Are you able to unmute yourself and ask your question for Gertrude?
All right. Hello?
Yeah, we can hear you for the most part.
Okay. All right, thanks. Thanks to the panelists for this conference. I just want to ask a question concerning stigmatization on HIV. I want to know if they are educating the religious leaders, schools, communities about it, because this is not only about girls. They have to educate them so that they can stop stigmatization, and also to the men. So I want to know if they are doing their awareness, if they are also working along with them.
Thank you, Trifina. At the moment, there are a lot of efforts in terms of education of HIV and AIDS issues in schools, and also even other NGOs which are trying to also go around and trying to educate people on HIV issues. But still, even after being educated on HIV issues, people are still stigmatizing people with HIV. So we don't really understand why the stigmatization is ongoing, even after a lot of efforts are being made. So in terms of the religious leaders, everyone is trying by all means to educate people on HIV issues, but stigmatization is still there. So I don't know how we can really deal with the issue. Thank you.
Thanks, Gertrude. Great. So now we've done with the questions, and I know we've only just got a couple of minutes left, but I'm going to put the panelists in the hot seat just to keep you awake at the end of the day and ask you to give a 1 minute really quick summary of a policy implication from your paper, if possible. I know that this is a tough one to make usually, but over to you in order. I know, Anisha, you kind of touched on this before, but if you have like a 1-minute summary / policy implication.
Yeah, I'm just emphasize something that that pushes on the demand for sun preference and tries to address that more directly. It could be targeted at children at a younger age. I know Seema Jayachandran has a great paper where she looks at the impact of a policy that tries to shift perceptions of girls for kids who are 13 to 16 years old. So I think something like that could have long-term impacts. But just focusing on bans and the like is not going to yield too much benefit, except on this very narrow margin that a ban targets.
Thanks so much. Gabriela.
Thank you, Claire. Well, definitely the topic of changing norms overall, it's complicated, but I would say that taking into account the findings that we have, particularly when we also incorporate the community engagement arm, would be to encourage policymakers for the different projects that they do implement, that they do focusing on girls, to also consider including the community in these activities and incorporating the community in the discussion. So it would be more related to targeting more actors, not only the girls, but also the community in general.
Thank you. Ahmed.
So the results pretty much suggest that gender-neutral policies, like constructing universities, for example, would benefit girls more than boys. So for a policymaker, any type of intervention that goes in the direction of making education more feasible and more accessible for people would definitely have positive impact on empowerment of women. And empowerment is not necessarily economic empowerment in terms of getting them into jobs, but also social empowerment in terms of getting them into better conditions in marriage and social empowerment.
Thank you. And Gertrude.
Thank you. I would say our results also suggest that female education improves HIV knowledge, and it also leads to less stigmatization of people with HIV and AIDS. And that was during the time where there was no elements of HIV issues being discussed in schools. So at the moment, I would suggest that governments should actually increase issues of HIV studies in schools, so that the elements of education that is being provided to the children, it entails a bit of HIV education programs more, because these issues are not really discussed openly at homes or everywhere else. So in schools, that's the best approach that governments could use. Thank you.
Thanks so much, Gertrude, and thanks so much, everybody. I'm really grateful that I got to chair this panel and read such interesting papers.